Welcome everyone to our second installment of the No Diabetes by Heart and Diabetes Inside Shared Learning series. Today we're pleased to welcome our colleagues from Jefferson, specifically the Jefferson Specialty Clinics, Cardiology and Endocrinology, who will be presenting about their quality improvement project that looks pretty broadly at finding ways to identify patients and then initiate appropriate patients on SGLT2 inhibitors to drive down their risk of future cardiovascular events. I want to thank our sponsors of this event, our founding sponsors, Novo Nordisk and BI Lilly, and our national sponsors, Sanofi, AstraZeneca, and Bayer. And without further ado, I will turn this over to Dr. Yair Lev, who's leading the effort on behalf of this quality improvement team at Jefferson, to introduce his colleagues and to walk us through their quality improvement project.
Hello, everybody. Today we're going to talk about the journey of the SGLT2 inhibitors at Jefferson Cardiology. My name is Yair Lev. I am a cardiologist here dealing with inpatient care and quality and safety. As such, I'm very interested in these drugs as novel and promising cardiac agents. So I will just say a disclaimer is that this portion, the first 15 minutes of this talk, are re-recorded because of a technical problem that we had during the initial presentation. So just keep it in mind. This conversation is going to be, and I really want to emphasize that it's a conversation. It's not going to be a formal talk about clinical trials and mechanism of actions of these medications, etc. We're just going to basically talk about our journey here at Jefferson, the collaboration between pharmacy and cardiology, heart failure, endocrinology, etc. So it's all about collaboration. And this talk is going to be really focused on brainstorming together with you, the people who are participating in this conversation. Please take notes, ask questions, make suggestions. We're really here to learn from each other. So just a little bit of a background how I got interested in these medications. So maybe 4 or 5 years ago, there was accumulating data that some of these agents of the SGLT2s, based on the trials that you see here on the screen, are really powerful cardiac medications and not necessarily only diabetic agents. And in fact, with time, we started reconsidering the essence of these medications. What is this class of medications? Are these really diabetic medications, or maybe cardiac or cardiometabolic, or both? So we started recognizing that these are really important medications. And in fact, they're pretty good for the heart medications in terms of longevity, MACE events, mortality, cardiac issues, rehospitalization, etc. Very powerful cardiac agents. And as such, I started asking my colleagues, mainly cardiologists or not endocrinologists, how frequently do you start using these medications, the SGLT2 agents, as an inpatient and as outpatient? And this was kind of the response of many of the cardiologists. We do not use these medications routinely. We're cardiologists. We're not endocrinologists. We're not medicine people. We don't have the time or knowledge to use these medications. So once we started really recognizing that these are powerful cardiac agents, we wanted to really assess the issue and assess the problem itself. And we started planning several quality improvement projects on utilization of these medications. And these wonderful residents were all participating in these projects. The first one in 2019 to assess utilization of these agents amongst different subspecialties in the outpatient world in 2019, both cardiology and medicine and even endocrinology. And the second part of the project, which we're really doing right now, is more of the inpatient. So I'd like to ask Dr. Francis, who's one of the third-year medicine residents, to talk about their experience of the project that they've run in 2019 on these agents in diabetic patients with cardiovascular disease, both coronary artery disease or heart failure, in the outpatient setting. So thank you very much, Dr. Francis, and please go ahead.
Well, thanks, Dr. Lev. My name's Matt Francis. I'm one of the third-year internal medicine residents. And last year, me and some of my colleagues had the opportunity to work on a quality improvement project looking at SGLT2 inhibitor use in diabetic patients as well as patients with cardiovascular disease. So in terms of defining the problem, obviously there's been a number of trials that have come out that have shown benefits to using this class of medication in the diabetic population as well as the population of patients with cardiovascular disease. So we've recognized that patients with a history of diabetes and cardiovascular disease should be on SGLT2 inhibitors as a standard of care. But we also recognize that most patients aren't being prescribed this medication. So we wanted to kind of further explore some of the reasons for that. As the first part of our project, we decided that we would take a look at our own physicians here at Jefferson. We surveyed physicians from a number of different specialties, including cardiology, internal medicine, family medicine, endocrinology. We wanted to survey them to get an understanding of their comfort level with prescribing these medications, as well as their frequency that they felt that they were prescribing these medications. And we had about 100 responses, half of which was internal medicine, but we also had a number of cardiologists, as well as other specialties who responded. And the following few slides are going to show some of the results, but this slide just kind of showed one of our questions and kind of how the survey looks. So for example, this is asking comfort level in prescribing these medications, and we asked them to rate this on a scale of 1 to 10. Now, if you go to the next slide. So this is showing the comfort level, and you can clearly see here that the comfort level for the average provider was quite low, averaging less than 5 easily, with most providers saying that their comfort level is between a 1 to a 3, with endocrinologists feeling relatively comfortable here at a 9 and a 10, but most internal medicine, family medicine, cardiology doctors are not very comfortable with prescribing this class of medications. And as you can see here, 68% of 68% of internal medicine doctors, 65% of cardiologists don't feel comfortable prescribing this class of medication. To further delve into this, we asked about reasons why this class may not be being prescribed very often. And this varied. Much of it had to do with costs, especially for internal medicine doctors, just not being comfortable prescribing this class of medication, maybe not being aware of side effects. And then also, especially for cardiologists, not feeling comfortable with changing diabetes regimens, being that diabetes isn't typically something that's managed by cardiology. Now, we also wanted to make sure that that these providers are understanding of the importance of this class of medication. Then I think that the survey showed that that was the case, especially with cardiologists and endocrinologists. You can see here that many of them understood that this was an important class of medications to be using in diabetics with cardiovascular disease. And you can see there that cardiologists seem to have a better understanding of the importance of this class than internal medicine doctors do. And then, as we kind of expected, we asked about the number of times that SGLT2s have been prescribed over the course of the last month. And, you know, unsurprisingly, internal medicine doctors and cardiology doctors, many of them had not prescribed any SGLT2s over the last month, whereas you're seeing some endocrinologists feel more comfortable using the medication. And to further get into the survey, we asked who they thought should be providing this class of medication. That's kind of in between a number of different benefits. There's cardiovascular benefits, there's benefits for diabetes control, and most providers felt that either internal medicine or cardiology should be providing these medications. So that gave us an idea of what people thought of this class moving forward. All right, so after taking the time to survey our own providers, we kind of understood what our providers' thoughts were about prescribing the medications, but we actually wanted to take a look at our patient population and see how frequently this class of medication was being used. And in order to do that, we collected a random sample of our own patients. These were family medicine patients, internal medicine patients, cardiology patients, endocrinology patients. And based on retrospective chart review, we tried to determine the patients who had diabetes, but also some underlying cardiovascular disease, specifically heart failure, coronary artery disease, peripheral artery disease, coronary artery disease. And we tried to see how many of those who would qualify to be on an SGLT2 inhibitor were actually being prescribed one. And of the 200 patients, 188 of them met inclusion criteria. So taking those 188 patients, we kind of broke it down to see how many of them were being prescribed the medication. And the results were quite interesting. So of our kind of specialists, endocrinology seemed to do the best at prescribing this class of medication to the appropriate population. About 20% of their patients who met the criteria were being prescribed SGLT2 inhibitors. But as you can see, many of the other specialties were not doing as well. So 158 patients and being seen by cardiologists. 95 of them met criteria, but only 11 of those 95, 11.6% were on an SGLT2 inhibitor. 8 patients were seen by internal medicine only and not cardiology or endocrinology. None of them were being prescribed an SGLT2 inhibitor. And 13 patients were being seen only by family medicine and not the other specialists. And only one of them was being prescribed an SGLT2 inhibitor. So all in all, looking at all of our data, only 13% of the patients who qualified to be prescribed an SGLT2 inhibitor were actually being prescribed them, which kind of confirmed what we thought was happening in our own institution. And this kind of highlights the endocrinologists who were doing a little bit better than the other specialists at prescribing. And like I said, the total number is about 13%. So in conclusion, we have the data. There's been the studies that definitely show that there's a benefit in using this class with diabetic patients with cardiovascular disease. However, looking at our own patient population here, we see that this class is not being used as wisely as it should be. And in asking our prescribers why that is, it seems to be that comfort level, cost, and their idea of who should be prescribing it has been playing a role. As far as our conclusion, there's obviously more work to be done here. And I think it's going to take a collaboration between a number of specialties, including internal medicine and cardiology, to determine who should be prescribing this class of medication, as well as getting the endocrinologist on board to help with brainstorming on how we can improve our prescribing practices here and come up with the potential solutions for the lack of comfort with prescribing this class of medications. All right, thank you.
That was great, Dr. Francis. Thank you very much. I think that what you have showed us is that we really, based on your project and also what we have gathered, is that we really underutilize these very important class of medications for cardiac patients. So we now know that we're facing a problem. So what will be the solution? So we actually kind of brainstormed and we thought about multiple different solutions, and I'll show you some of them. We created a task force, endocrinology and cardiology. We started education by emails, lectures, and grand rounds. And for example, this is Dr. Kovatsas, who was my partner on this before she left Jefferson to the mainline health. And she gave us the grand rounds, one of the first grand rounds that we had on Zoom because of COVID. This was probably in April of 2020. So we had several QI projects, faculty meetings, efforts both inpatient and outpatient, working with pharmacy on the pricing. We even created these tip sheets for providers, inpatient and mainly outpatient, to basically look at how to start easily these medications, an easy dose, where does it work, and what do you need to keep in mind when treating these patients. So I have also, as part of kind of like an emergency need for financial assistance, etc. I have the personal cell phone of all these companies who assisted me when I had any financial issues for some of my patients, inpatient or outpatients. But I think that the most important project that we have launched, and it's still undergoing, is with Dr. or CRNP, nurse practitioner Clancy. She is fantastic, and she's coming from the endocrinology division, but she has also a lot of background in population health and research studies, etc. So we were funded by the ADA, and we're grateful to that, and the No Diabetes by Heart. And what Christine, I'll just explain briefly what she has done, and then I'll let her take over. Is she's basically sitting in the cardiology office, and on Fridays she reviews all the patient charts who are going to be seen at Jefferson Cardiology Center City the following week identifies who has an indication to be on these medications, and then communicates with the cardiologist. And this way, basically, we're able to not only track information and data, who prescribes, why we prescribe, but also follow up and have an actual intervention of reminding the physicians to utilize this very important medication. So Christine Clancy, who became friends throughout this, thank you very much, and please take it from here.
Hi, I'm Christine Clancy. I'm a nurse practitioner with Jefferson Endocrinology. I'm working on a separate part of this project we call it Outpatient Proactive Notifications within the cardiology department. So what we do is I have a half day a week dedicated to do a process where I go, originally was in the cardiology department physically, but then during COVID, we made it a virtual process. So I log into Epic under the cardiology department rather than endocrinology. I run a report that was built by Dr. Babula, one of our physician Epic leads. The report will pull for the patients coming in to see Jefferson Cardiology at the 925 Chestnut location, any patients the following Monday through Friday that have diabetes listed on their problem list, along with either some kind of atherosclerotic cardiovascular disease or congestive heart failure. They built it so that it would hopefully eliminate patients with type 1 diabetes, as well as patients that are prescribed any insulin. That doesn't always happen, and it does require a little bit of filtering. So each week I run this report. I export it to an Excel spreadsheet where we can sort it by, generally by GFR, eliminate any duplicates, any duplicate patients, or entries that are now expired. We decided that while I was looking through each chart to notify the providers of patients that would be good patients for an SGLT2 inhibitor, that we should probably track what I'm finding so we would have some good data throughout this project. So what we did from that Excel spreadsheet, from the report, we added additional columns and I built some drop downs where we'll look to say, is the patient already on an SGLT2 inhibitor? During the project, we also decided to add an additional piece where we would look to see who's the person who started the SGLT2, whether it's cardiology, endocrinology, or PCP, or sometimes it's just difficult to find if it's listed as a historical medication. After that, I look through the chart to see, does the patient look like they're a good candidate for an SGLT2 inhibitor? If yes, a notice is sent to the provider that has seen the person that next week. We have an Epic dot phrase that we gives just a quick summary of the project, tells the providers that this might be a good medication, gives some examples, and just refers them to another dot phrase regarding side effects. We decided to track our reasons where patients may not be good candidates for an SGLT2. So GFR was one of the bigger ones. We decided to use insulin or sulfonylurea as an exclusion because of the risk of hypoglycemia and not wanting the cardiologist to have to deal with doses adjustments or hypoglycemia. Type 1 diabetes as well, because of the risk of DKA, as well as you can see the other possibilities for reasons for no. We did evolve the process after the first several weeks to show that patients on the insulin or sulfonylurea use that we were excluding, we did change the process to then notify the patient's providers if they were within the Jefferson system. So we built a separate smart phrase to notify that PCP or that endo that this patient might be a good candidate for an SGLT2. If not, unfortunately, it's difficult to track down how to notify people outside the Jefferson system. So it's just noted there. So if I do find an eligible patient, we're trying to find ways, not only a notice, a staff message to the providers, but I also will put in under the and this is the reason I log in under cardiology, is within Jefferson, or within all Epics, actually, there's a way to put specialty notes that anybody within the cardiology department could see that little blue note next to the person's name. So I'll put the date and put possible candidate for SGLT2. Under the personal sticky note that is only for myself, I also kind of track what's been happening, whether I've sent a first notice, second notice. I can find that on my tracking spreadsheet, but it's just a little faster to do it this way as well, rather than going back every time and trying to look through my multiple spreadsheets to find the patient. So this is just a way to kind of keep the flow going as well. Next slide. So these are the findings that we have. I gathered the first 12 weeks of the spreadsheets, the second 12, and then combine them. As you'll see, there's a lot of charts reviewed, but then I eliminated all the duplicates to find out how many unique patients were actually reviewed during those timeframes, and then figured out the percentage of patients on SGLT2, which you see the numbers are still quite low, and which providers were notified. So over the combined 24 weeks, there was 218 patients that the provider was notified once or twice or sometimes 3 times about the patient's eligibility. I gathered the most prevalent reasons for ineligibility. GFR was consistently the reason why people were excluded week after week. The insulin sulfonylurea reuse was actually a little bit higher than I thought it would be. The report is supposed to exclude patients on insulin, but the EPIC report isn't perfect. So there's people that are on insulin for some reason were not excluded from the list. So of those people, many of those were within Jefferson and notices were sent to the providers. Pre-diabetes was also a little higher than I thought it would be, but I think for some reason, a lot of those patients just got pulled in, whether there was a diagnosis code put in at one point into EPIC to get an A1C drawn, I'm not sure, but that's one of the higher reasons than I thought it would be. Not enough data is not uncommon, just because people do come to Jefferson Cardiology from throughout the area, and sometimes the data is just not in EPIC. And the GU issues were also. The miscellaneous was a wide range. I mean, there were people going on hospice, a lot of falls, people with inpatient with urosepsis. We didn't want to include those. A lot of just gait issues, fall issues, things like that. So the biggest challenge is that EPIC report isn't perfect. The volume seems to be manageable. Some weeks are definitely a little bit longer than others. But sometimes I spend a lot of time going through a chart just to find out that the person actually does have type 1 diabetes or is on insulin or something else that excludes them. The volume varies. Luckily with Jefferson has a very robust telemedicine program. So the patients that even have telemedicine visits with the cardiology deals still do show up on my list. So I think that helped during COVID not to have a small volume of patients. One of the biggest challenges I have every week is the data that's not in discrete fields. So I have to do a lot of searching, whether it's a scanned lab in the media section, I go into Care Everywhere to see if I can find a latest creatinine. That definitely takes a lot of time. Some of the aggravations are those cancellations and no-shows, because there's charts I go over, then I go back and see why did the cardiologist not prescribe the medicine, found out the patient has no-showed or canceled the last 3 visits. So it gets repeated notices sent to the providers. And I try to note to them that I understand this is a duplicate, but since the last one was sent 3 months ago, I don't want to not send them another notice. So sending that. And of course, doing the chart review is one thing. The tracking is also pretty time consuming, although we know it's very important to have this data, but it definitely takes an extra step to do all of this. So the interesting thing, which really ties in to some of the findings that Dr. Francis just presented as well, is that there is still a lot of education and resistance. And these are direct quotes I've taken from the charts. When I look at I'm sending the second or third notice and finding out, did the patient or did the cardiologist even address the SGLT2? Sometimes there's no mention whatsoever. But some of these are very interesting, like where they'll go over great detail about the benefits of it, but then they defer it to the primary care provider. Or they're just saying, oh, well, the A1C is great, and leave it at that, even if they mention anything about SGLT2. So this is what I think is very interesting as well, that there's some providers that are definitely much more comfortable. And it's interesting when I do see that it's, I suggest send the notice. And then when I look at the chart again, that the prescriber or the provider did prescribe. And the same thing with the PCP, some of the notices I sent are doing so. When I did break down of the people who I have looked at the charts again, and I have not gone back, I just don't have the time to go back over every chart that I've sent a notice. But as I'm doing the chart reviews over the 24 weeks, I looked back over all the yeses. Some of them were no's in the beginning and have moved on to yeses. But out of those, 26 of the SGLT2 prescriptions were by primary care providers, 17 were by endocrinology, 14 by cardiology, and there was another 40 where I have no idea. It's on their chart. I look back as far as I can without spending a half an hour looking through, and I just can't tell who started it along the way, whether it was inpatient, cardio from somewhere else or somewhere else with outside Jefferson. So that is it for my data.
This was awesome. Thank you, Christine. And I think that this is the most important part of the presentation, because this project has had it's very important, both for data collection, and you showed that it's about 10%, kind of like what Matt showed before. And the main issue, my biggest take of what you're saying is that there's still a lot of resistance amongst the community of the cardiologists to start this medication for different reasons. But it's really a matter of comfort, and they still think about it as a diabetic medication and not a cardiac medication. Now, one thing that I wanted to remember, Matt showed this reasons for not prescribing, and a big one was cost. People are afraid of cost. These are new medications. The out-of-pocket can be crazy, variability, etc. And because of this, I invited and I wanted to ask Eric Schifrin, who's one of our endocrinologists, and he's the head of the Director of Quality and Improvement for Endocrinology, and he's a big partner in this project. And I wanted to ask him if he can speak a little bit about what he has found and tips that he has in terms of cost management of these medications. So thank you, Eric.
Thanks, Yair. I was lucky enough to take over for Dr. Tasha Cavazos that Yair mentioned earlier, and excited to be a part of this project. As an endocrinologist, prescribing these medications, in patients that do get a prescription, some of the barriers to use after it's prescribed, certainly side effects is one aspect, but things that we run into and can be very frustrating, just with insurance coverage, the need for prior authorizations, the work it takes the office and our medical assistants to sometimes the paperwork and back and forth is a long process, and certainly cost. So coverage is improving for these, and Medicare has actually been pretty good in putting a lot of these on the formularies. Commercial plans have been mixed. I wanted to just focus on some of the Medicare plans. The barrier to some Medicare patients getting these medications, and a lot of the Medicare patients are the ones that do meet criteria since they're older and the ones with cardiovascular disease or congestive heart failure. Although they might be on the formularies, the out-of-pocket costs really add up, and really we get messages all the time. I went to the pharmacy and the pharmacy said it's going to be $500, and that's obviously unreasonable for almost anybody, and they end up not picking up the medication. So the Centers for Medicare and Medicaid Services it's been in the news recently, the cost of insulin, and there have been some initiatives to lower the cost of insulin or cap the price of insulin, but medications like SGLT2s are not part of any initiative just yet. This just gives you a little bit. This is some 2019 data. Their 2020 data probably will be maybe out soon or is out, but this just gives you a flavor of probably the three most popular SGLT2s that we prescribe: Jardiance, Farxiga, and Invokana. And the coverage on Medicare plans is pretty good, especially for Jardiance, 98%, 65% for Farxiga, 57% for Invokana. But if you look at the average out-of-pocket costs, they're generally $1,000 or more per year, which for a lot of patients on fixed income is too much. So as a result, one of the interventions that we sort of just recently started to ramp up getting some pharmacy assistance with some of these prior authorizations, or looking into financial assistance or charity care for a lot of patients, whether they have Medicare or commercial insurance for that matter, or one of the government insurance plans, has been really, really helpful. And we plan to start tracking data and getting some hard numbers on the number of patients that are able to get on these that aren't able to. So what the pharmacy does for us, and they kind of go through an algorithm. Any patient that the cost seems to be too high, they look into some copay programs through the manufacturers, charitable foundations, Jefferson Charity Care. They'll see if they're eligible based on income. They take a look at the patient's W-2, Social Security income, and they may meet criteria to get some assistance or full charity care. Patients that don't qualify for these options, there are some manufacturer-free drug programs, payment plans. A lot of this stuff is things that patients just don't have time to do. They don't know about them, and so getting assistance from quote expert pharmacist has been really, really helpful.
So this was awesome. Thank you very much, Eric. And I'll just comment that I do mainly inpatient, but my outpatient weekly practice is the Latino population, the uninsured, undocumented, that are managed by the health center system here in Philadelphia. And unfortunately, it's supported by the city and the state, but unfortunately, and I work very closely with Health Center 6 and 2, and they don't have any of these agents. So unfortunately, we can't use them. And obviously, within the Latinos, we have a lot of diabetes and cardiac disease. And at this point, we can't use these medications yet, but they're working on it. So thank you very much, Eric. And again, it's a complicated system, and there's so many insurances and sub-insurances, but I think that Eric is helping us with the assistance of pharmacy to crack the system and treat our patients better, and that they will be able to afford it. So we talked a lot about outpatient, but what about the inpatient setting? And why is it so important? So it's important because, very briefly, there's evidence based on several articles and publications that if you use it as an inpatient, you can reduce length of stay of readmissions. Also, you can monitor complex patients with kidney disease and monitor the creatinine throughout the admission. You can convince the primary inpatient team to discharge them with the medication with SGLT if they have tolerated well throughout the admission, and most of them do tolerate well. And then also, as part of what we do at Jefferson, the inpatient always communicates with the outpatient cardiologist. Ultimately, what we have done for the patient, we tell them, listen, we started this patient on an SGLT2, tolerated well, and he will be discharged, he or she will be discharged with this medication. So with that, I would like to move to the last quality improvement project. Like I said, that there were several quality projects run by the residents, and I'm going to turn it out to Andrea Rivera, who's going to talk about the assessment of utilization of the SGLT2 in the hospital. Remember that the first project was more of the outpatient. So thank you.
All right. So to take off of, hi, I'm Andrea, by the way. Thanks, Dr. Lev, for introducing. So to take off, can everyone hear me? Unfortunately, I don't use. Perfect. Very well. Right. So to take off of what Matt, off of Matt's project and off of what Christina was saying, Matt's project last year focused on outpatient utilization of SGLT2 inhibitors. So our project this year is a continuation of that, and instead of outpatient, we're focusing on inpatient. So to continue what Dr. Lev had just mentioned, why focus on inpatient utilization, especially since SGLT2s are primarily a preventative medication. So there's something that you see more in the outpatient world. So a couple reasons, I'm probably going a little bit out of order on this, but so three main reasons that we really wanted, that we wanted to focus on inpatient utilization. One, simply put, inpatient data, as Christine can probably attest to, inpatient data is a lot easier to collect and analyze than outpatient data. The patient is in the hospital the whole time. You're able to see what happens when you initiate a medication, what happens immediately afterwards. Two, as residents, this for me personally, and for our team, as residents, we have a lot more control over inpatient medications and inpatient prescriptions than we do over outpatient. an easier place for us to possibly intervene. And three, probably one of the most important aspects, as Dr. Lev mentioned, oftentimes it is easier, thanks, it's easier to actually start patients on a medication and have that while they're in the hospital and have that be continued as an outpatient than it is to ask the primary care or the outpatient provider to follow up on yet another thing as an outpatient. So for all of those reasons, we decided to focus our project on three things. Sorry, Dr. Lev, do you mind just going back to one slide before that? Thanks. So we decided to focus our project on three things. One, first, we wanted to see whether or not these medications were being appropriately used in the inpatient setting, meaning that are people who are eligible for an SGLT2 inhibitor getting discharged on one. Two, so that answers that first question. Two, our second question from there is, we wanted to survey cardiologists, endocrinologists, and hospital medicine physicians about the potential barriers that they saw to prescribing SGLT2s as an inpatient. And third, and probably one of the most important things, with significant help from the Department of Pharmacy and other people who've already worked on this on their side, we actually were able, the hospital was just able to add dapagliflozin and canagliflozin to the inpatient hospital formulary in September of last year. So with that, we're taking a look at the data for 1 year of SGLT2 prescriptions prior to adding the medications to formulary, and then the data on the number of SGLT2 prescriptions after it was added to formulary to see if this does present a significant increase or maybe doesn't make much of a difference at all in terms of how often they are utilized. Dr. Lev, do you mind? Thank you. So this here is a screenshot of our survey. We kept it brief because people are busy and we're sending it out to cardiology, endocrinology, and a hospital med, as we've mentioned previously. Do you mind? Thank you. So to analyze, as I had mentioned, to analyze inpatient use, we took a selection of data for 1 year for all patients who were discharged from an inpatient cardiology service or a inpatient service that had a cardiology consultant. And we looked at patients who were adult patients who had diabetes and coronary artery disease or diabetes and heart failure. We did exclude anybody who had a history of DKA, anybody who had a history of type 1 diabetes, because they were at risk for DKA. We looked through from that, and from that list, we excluded people who had a baseline eGFR of less than 45. And for that, that involved us actually looking through some of the patients, because obviously when people come into the hospital, they often might have AKIs, etc. Temporarily decreasing their GFR. And finally, we excluded patients who were unable to be started on a SGLT because they left AMA or they unfortunately expired or were getting discharged to hospice. So one of our most important findings to date shows the pretty incredible underutilization that we have right now of SGLT2 inhibitors. So for the 1 year period between July and 2019 and June of 2020, we in our hospitals, so over Methodist, JHN, and Thomas and Center City, there were only 3 new prescriptions of an SGLT2 inhibitor over that entire 1 year, which is pretty incredible. From that period on, we've started analyzing the data from September to our present date to see how the increase in SGLT2 prescriptions increased after they were added to formulary. And so far, our preliminary data shows at least 12 new prescriptions of just dapagliflozin, and we are still waiting on the canagliflozin data. So there are a couple different things that could be contributing to this. the most obvious answer would be that it is easier to prescribe. It is easier to prescribe these medications now. Anybody who's had to, if prior to this, if you wanted to prescribe an SGLT2 inpatient, you either had to use a non-formulary or a patient-owned medication, which can be difficult to coordinate and just difficult to order. But there are also other reasons. As I forget who, somebody had mentioned earlier, there's been a lot more education about SGLT2 inhibitors, both outside in professional societies and in the hospital itself, including grand rounds that were held here. There's also just been more information about SGLT2 inhibitors in the world at large. I actually recently was able to prescribe an SGLT2 inhibitor for the first time to one of my primary care patients. And when I'd mentioned the medication, his response was, "Oh, that's the one I saw on TV." So all of these things do contribute to, I believe, do contribute to overall increased utilization. And just a quick slide, we also did, as part of our analysis of things that we can intervene on, we did take a look at what are all the potential barriers to SGLT2 inhibitor usage thus far. So with that, I will pass this on to Nicole, who I imagine is going to be speaking next, who actually has been incredibly helpful in increasing our dapagliflozin usage in patient. So
she's going to talk more about the data, but
thanks. And so our last thing, as we'd mentioned, one of the things that had come out of the fishbone diagram that we'd done earlier was to look at places that we could possibly intervene to increase utilization. So some of the things that we had talked about were possibly adding an Epic best practice notification similar to what Christine does, but not quite as nuanced as actually having someone being able to sit through and review the cases themselves. So having a best practice notification to inform providers that a patient might be eligible for an SGLT2 inhibitor and to consider starting it while inpatient. Second from that, we wanted to consider putting in a intranet guideline or checklist, especially for the residents, because we realized among ourselves that there's still a lot of confusion about when and how and in what situations to start SGLT2 use. And our two last interventions are increased education. So in addition to a guideline or checklist, more hospital-wide education through events like grand rounds, and more resident-specific education through education series for both the residents and the interns. So our summary for our inpatient data is that we have pretty strong data that these medications are not getting utilized nearly as much as they can and should be. And so over 1 year, we only have 3 prescriptions, which is, again, incredible for something that has this strong data. For a medication that has this strong data, that's pretty shocking. And it's not even a new medication either. This has been around. This has been something that we know works. And this is an easy intervention to make. So that's our project.
That was excellent, Andrea. And thank you very much for this very sobering data. And my take on this is yikes, and that we have a lot of room to improve. So I'm going to move to the last segment. We're a little bit over time because it takes time to coordinate with everybody and hear everybody's opinions. But the last thing, and you mentioned, Andrea, about the formulary, that if we do have it on formulary, maybe it can help CHF treatment throughout because it has a mild diuretic effect, and people will prescribe it more frequently for different reasons if we have it on formulary. So the thought was maybe we can take it to the P&T committee, and Tasha and myself and Eric basically encouraged, and we got several people involved from pharmacy, but I would say also the leaders of CHF and leaders of endocrinology and leaders of cardiology to help us support our agenda with the P&T, the Pharmacy and Therapeutics Committee. And indeed, we got 2 agents approved in September, just a few months ago. And the question is, how has been the rollout so far? So we're lucky enough to have one of our pharmacy residents, Nicole Hennessy, who's going to tell us a little bit, just for a couple of minutes, about the data so far, about how this rollout has been happening so far. So thank you, Nicole.
Thank you, Dr. Lev. So as Dr. Rivera had mentioned, back in September of 2020, Thomas Jefferson University Hospital actually added dapagliflozin to our formulary here. Of note, at the same time, canagliflozin was added, but dapagliflozin was added with certain criteria for use by our P&T committee. So this criteria for use was reflected based off of the DAPA-HF trial, primarily targeting patients with that heart failure indication. So patients with an ejection fraction less than or equal to 40%, with NYHA class 2 to 4 heart failure, and patients were excluded if they had type 1 diabetes or any sort of renal dysfunction. And I was able to pull data from the first 4 months of usage.
Just note here before you go over the data is that this is an ADA sponsored and there's a lot of diabetes in this, but this actual inclusion criteria do not include necessarily diabetes. You don't have to be a diabetic in order to basically be included for using this medication, just because we have a lot of data now that for DAPA specifically, and it's FDA approved to use for patients with systolic heart failure, regardless of the diabetic status. It's important to mention.
Yes, thank you, Dr. Lev. And that was, so patients that did not meet that specific criteria for use, the idea is that they would utilize canagliflozin while inpatient. So during that 4-month period, I captured 52 patients with dapagliflozin orders during their inpatient stay, with an average age of about 63 years. Of note, no patients had type 1 diabetes, and there were actually 8 patients who did not have diabetes at all, which is interesting and goes to Dr. Lev's points that there is a heart failure indication and it can be utilized outside of diabetes. Of note, though, 20 patients out of the 52 did not actually have NYHA class 2 to 4 heart failure or a heart failure diagnosis in general. Next slide, please. So the ordering characteristics, you can see here there's a variety of disciplines ordered the dapagliflozin while inpatient, a majority being internal medicine. There were a few specialties that you wouldn't normally associate with SGLT2 inhibitor therapy, so orthopedic surgery. And this was primarily due to just medication reconciliations and continuing medications from home. But interestingly there in the middle, you can see that there were 14 of these patients were de novo therapy. So they were newly started on SGLT2 inhibitors. And I don't have the exact statistics on me, but these patients for the most part were either their attending team was a cardiology service or they had a cardiology consult in which it was recommended to start this de novo dapagliflozin therapy. The other 38 patients were just continuations from home SGLT2 inhibitor therapy, whether that be dapagliflozin or empagliflozin. So of those 14 new starts or de novo with dapagliflozin therapy, 12 out of 14 met our criteria for use as outlined by our P&T committee. So again, we'll touch on this a little later, but that criteria was developed based on the price difference between dapagliflozin and canagliflozin. So here it's pretty successful, these new starts in therapy. The 2 patients that did not meet criteria just had some kidney dysfunction that would have excluded them from new starts. And here, so that 22 number that is highlighted, those 22 patients did not actually meet our P&T committee's criteria for use. So while they may have had diabetes and outside the hospital, it would have been appropriate per our specific P&T criteria, these patients did not have the, you can see on the right, they either did not have the heart failure diagnosis or they had kidney dysfunction or simply just a medication reconciliation. And so I alluded to this before, but the big difference here, or the big driver for, internally our P&T committee had to do with price. Canagliflozin is significantly cheaper. So while using this inpatient, we really wanted to save the use of dapagliflozin for patients with that heart failure diagnosis, since it is significantly more expensive and cost is something you have to take into consideration in the inpatient setting as well as outpatient. One thing we were able to look at a bit were 30-day readmissions. So of note, this only captured patients at our Jefferson Health that had their charts in our, in our EHR, so in our Epic system. So of the 52 patients, 39 I was able to check if they were readmitted within 30 days for a heart failure related diagnosis. And of note, 38 were not, but 1 patient was. Interestingly, this patient was readmitted for a heart failure related diagnosis, but their initial admission when I first captured them was actually not related to heart failure. But again, this isn't a soundproof 30-day readmissions, but it was interesting to see what we were able to look at related to the heart failure data. And so for future directions, so we do want to continue to maximize, as everyone in this project has reiterated, maximize the use of dapagliflozin in these heart failure patients for the cardiology purposes. So we're hoping we can utilize our AHR to create best practices advisories, help out with the medication reconciliation to make sure it defaults to either canagliflozin or dapagliflozin based on our P&T criteria for use. And we're hoping to continue moving forward.
That was excellent. Thank you very much, Nicole. I think that it's your data. My summary or my take on this is that it's improving, and I think that it's a process. But I think we should be cautiously optimistic about the utilization, both inpatient and outpatient. So we're done with all of our presenters, and now I'm going to take just a minute to summarize everything. Recall that before 2016 or before 2020, these class of medication, the SGLT2, were considered diabetic medications with maybe some cardiac benefits based on several trials. But there's been a big paradigm shift. And now the present, these are really considered powerful cardiac medications. And maybe they can lower glucose, but you don't need to necessarily use them. You can use them also for patients without diabetes. And I think it's very important to highlight that in the world of heart failure, for example, this has been a dry desert for many, many, many years. For 20 years, there's been no new medications for heart failure. The new medication that popped up a few years ago based on several trials, Paradigm, HF, etc., was Entresto. And when Entresto came, there was such excitement in the cardiology community. It was insane. Everybody were talking about it. But when the trials on the DAPA and the Jardiance and all these medications came and showed that there are some cardiac benefits, the cardiology community were not so interested. And the reason, I believe, is that it's really considered a diabetic medication, and we don't want to deal with diabetic medications. It's not our specialties. But guess what? We will. It is a cardiac medication. And in the same way that 30 years ago or 20 years ago, when there started being so many trials that show that the statins are so effective for coronary artery disease, at first the cardiologist was like, oh no, we're not going to touch these medications. This is all the domain of the primary care physician, the family medicine, the endocrinologist, it's cholesterol. We're not dealing with cholesterol. And guess who's the master of statins now? It's us, the cardiologist. So I think it's just a matter of time, but we are, in the midst of the paradigm shift. So future ways to improve utilization of this very class of medication, just to summarize, conferences like this one, collaboration between the departments intra-hospital in Jefferson and also different hospitals and different systems. And I appreciate the ADA bringing us all together. QI project, task force, metabolic clinics, learning from other systems. We've been working and learning from Columbia and Geisinger, what they've been doing, grand rounds, tip sheets. And a big question that I have is, who's going to be owning this? Is this something that the primary care physician, Dr. Ward, is going to be prescribing, or is it many cardiologists who are going to be prescribing these medications? EMR, best practice advisories, dot phrases, and working with our pharmacy. So with that, I'm going to conclude, and I wanted to thank everybody joining us, and specifically all the people who presented, our excellent residents, Matt and Andrea, and Christine Clancy, who's been doing an amazing job, and Eric Schiffen, who's been a great partner, and of course, Nicole, who did such a superb job on analyzing and reviewing the data after the formulary. So with that, I'm going to end, and thank you, everybody, for listening to us.
Thank you, Ari. That was fantastic. All of the different interventions spanning so many different processes and workflows is really what quality improvement is all about. And to see data on each of those is wonderful. And I think informs us how challenging this is, right? How many different departments and professionals are involved in trying to figure this out. Layering on the technology and some of the challenges of who is responsible or who should be responsible for really managing these patients. So I'll start with a question. I know we're getting a little short on time, but in the feedback, Christine, that you collected on some of your alerts to the providers when you went through your process of identifying patients, a lot of that was kind of the punt back to primary care, right? So what have you found to be effective in communicating with primary care to manage that patient, or where do you take it from there?
So we actually don't have a process built in for that because right now mine's just the proactive outreach. So if I see that note, I still send another notice to the cardiologist once again that, that this is an eligible patient for them. Really, the only interaction I'm having with primary care is those patients on the sulfonylurea or insulin. So again, it's kind of it's a time issue. There's some weeks where I can barely have the time to get through the number of charts for cardiology and it's already stretched. So, I mean, that would be a nice next step if I had time then to reach out after, because it would take me looking back at every chart I reviewed to see what the outcome was and then follow up with primary care if they're within Jefferson. And that would really be actually a full-time job. So, and I get 4 hours a week to work on this. So, I mean, it is something, and I think we've mentioned along the way here, some things like the EPIC best practice advisories would be nice if within cardiology, endocrinology, and primary care, if patients met these criteria, if there was something that popped up when we're seeing the patient in the practice for a regular visit, that would remind us that this person has cardiovascular disease and this would be a good choice. So, right now, my focus is just on cardiology, and my interaction is only with primary is only for those patients, say, on insulin or sulfonylureas.
Greg, I also wanted to comment that this is remember that this is a process. We know that this is going to take time. We need patience, and we started deliberately to kind of exclude these people with sulfonylurea, for example. But because we didn't want to let the cardiologist deal with this and stopping medications, but honestly, what a lot of us are doing, or some of us are doing, or just when somebody is on an SGLT, we want to start an SGLT2, and a patient is on glipizide. What I do sometimes is just eliminate the glipizide, and I don't see a big. This is after I don't do it on my own. It's after multiple conversations that I have with Tasha and Eric. I just don't see in cardiac patients. We don't see the great benefit of sulfonylurea in these patients in terms of reduction of A1C necessarily, and and we see a much better benefit with the SGLT2. So I think that this is all a process that we're moving forward something, and we're tweaking it along the way.
Thank you. Any other questions with the time we have left from other folks from our partners?
Well, this is Bill Morella. I've got a quick question for Christine. Well, first of all, thank you to all the presenters. Great overview of the projects that you're working on. This is really important work. Christine, I was curious when you were talking about your process, can you clarify what the initial scope of patients is that you're looking at? Are you looking specifically at people who are scheduled to be coming in? Or, are you looking sort of across the whole health system for anybody who meets your criteria at that point in time? No, thanks for clarifying. So the report is run and is built that it looks like any patient who's seen the cardiology department at 925 Chestnut, because they have multiple locations, but we decided we'd start with a volume that was manageable, who are being seen by any cardiologist in the next week. So I do the chart review on Friday. I run the report from Saturday to Friday. So it's a week's worth of patients that are coming in, and that's so that way it's a closer notice to when the person is going to come in and see the cardiologist, because we didn't want to alert the cardiologist 3 months before they see the patient. Mm-hmm. I note when I send the dot phrase that has the little thing, this person has been identified as qualifying. I even put in the title, possible candidate for SGLT2 appointment next week. So they know that person is coming in sometime that next Monday through Friday that they can identify. Now, what the cardiologists do with that data, I don't know. I think you would have to address that. Yeah, the reason I was thinking about that, and the reason I asked was, we're thinking about from Health Share Exchange's point of view, we have a lot of automated processes that are notifying PCPs in particular about when their patients are coming out of the hospital. So if you're trying to, initiate SGLT2 while someone's an inpatient, we can augment that encounter notification with information about their potential being an SGLT2 candidate, and communicate that to the PCPs, possibly shortly before they're coming in. So maybe take that offline and figure out how to make that work. But it sounds like that may be a gap we can help fill.
So let me just, this is Larry. I'm just gonna be a little bit of a devil's advocate here. That paperwork about prescription suggestions, honestly, is never even opened by primaries. I'm just being honest. We take that and we throw it away because we get a billion of them. I think this is great, and it was a great presentation, and I think your enthusiasm for this subject is apparent. My concern is that a lot of initial QI projects base a lot on education and epic BPAs, and it's not sustainable. That said, with this sort of project, which is really trying to change, and gain, I think, greater appreciation and sort of inculcate it in our thinking as we move forward, I don't think it's necessarily the wrong thing to do right now. But we cannot base it on PCP, throw it one more thing back onto the PCPs. I think we have to maintain this as a multi-specialty effort. And I think you've done that, and properly so, that I think it has to be endocrine, it has to be cardiology, it has to be primary care, it has to be across the board, and wherever and whomever notices that, hey, this person would benefit from it, needs to just make that change. So I think, yeah, you're honestly, I think primaries will get into this and we'll educate on it and all that. I think the harder one are going to be the cardiologists to take on a diabetes agent, quote unquote diabetes agent, and get them to do that. The endocrinologists will do it. Primary care eventually come around a little bit later. It's the cardiologists that I think are the key to this, to really making the change. When we start seeing cardiology is starting, whatever drug, flows in, that's when we're going to be really taking note, I think, and really change practice.
I totally agree with you. And I have to comment that I think that that's probably one of the main reasons that we decided to do this project with Christine on the department or the division of cardiology rather than, spread out.
I agree.
And also remember, I think that we are now at like I said, I think that this is a process. And in 5 years, I suspect that this is not going to be any more conversation related to diabetes. It's not. It has, Eric knows better than anybody how effective it is in terms of reducing the A1C and this and that, but it's really, there's more and more. FDA is probably going to approve Jardiance very soon for the utilization of systolic heart failure, regardless of diabetes. For DAPA, as you can see from the P&T and the formulary, we use it in the hospital, regardless of the diabetes status. It's no longer a diabetic medication. These are cardiac medications, and it should be, and that's why we're so much focused on the cardiology. And I think that Renee Alvarez, my boss, who is a heart failure specialist, and Eddie Rami, all these people, they're really building a CHF practice, kind of subdivision within cardiology. And I'm working very close with them because they are the leaders. Right now, it's really a medication for systolic heart failure for several mechanistic reasons. And I think that they're going to be really helpful in this environment. But I totally agree with you, Larry, that this is really, the onus should be on us, on the cardiologists, not primary care physicians. And also not endocrinologists, because think about it, how many endocrinologists we have and how many cardiologists we have. We can't expect every diabetic with a A1C of 6.5 and metformin to be seen with endocrinology. That's why it shouldn't be the responsibility of endocrinology. It should be us, the cardiologist, predominantly, I think.
Christine, can I ask a question actually? When you are going through this, have you, I guess this is also going off of what Dr. Schifrin was saying, but how often have you heard back from cardiologists or the primary providers or whoever you're reaching out to that cost or insurance authorization, et cetera, is the barrier? Or do you see that in the notes in the follow-up?
I don't see it in a lot of notes. I have seen some when I go back in to see that I've sent a notice, and now I'm going in and sending a second notice because they still qualify, where there is sometimes some communication with the cardiology RNs trying to go back and forth, trying to get something approved. And there's occasionally somebody I'll notice that I look and it was a yes, they were on an SGLT2, and now I've reviewed the chart again and I all of a sudden find out they're not. And I look, then I dig into further to find out why did the SGLT2 disappear? And if there is notes, it usually is related to cost, or the person hit the donut hole, or they're just not going to. Only I think there might have been one or two patients where it looks like when it disappeared off the list, it was because they couldn't tolerate the side effects. So that was much less than the actual cost. But sometimes once I send a notice and then they're on it, I don't know. I don't know if some of those people that ended up not on it, was there an outside conversation that I can't see that was related to cost? So, but I'm sure it's there because we see it within endocrine, where we prescribe the medicines and people get back to us and say, absolutely not, I can't afford this drug.
I guess one of the things I'm wondering for that is there any difference in coverage or copay or cost depending on what the indication is? So if you make the indication for heart failure versus diabetes, or if it's the cardiologist prescribing it versus the endocrinologist versus the PCP?
No, it is the drug's the drug.
Doesn't differentiate.
Yeah.
But I think you're right, Andrew. I think that with time it will, because again, there's more and more data about the utilization of these medications as cardiac medication. I think it will be easier to prescribe them for cardiac patients. Greg, can I ask a question?
Sure.
This is a question that I have for Dr. Skofalos. Hearing all of this and all the barriers that you see, that it's really mainly education and comfort. And the way that I see this is that the cardiologists know that these are excellent cardiac medication, but in their head, it's still diabetic medication, and they really don't want to deal with it. They don't want to deal with it. They have 15 minutes per visit, and they're dealing with a blood pressure and this and that. The last thing that they need to, that's what they tell me when I talk to them, is to reduce the insulin and play with this and play with that and reduce this. And how would you think from a population base, will we get to a point that we can expedite this transition? That was a question to Dr. Skofalos. I don't know if she can.
Yep, nope.
Oh, yeah.
I started talking and forgot to unmute. Sorry about that. No, it's interesting. I was thinking about putting something into the chat, because honestly, this is where interprofessional education really it just highlights all of the need for, the need for that and how important it is. You know, our patients have one body, and everybody's dealing with the separate systems. We can't compartmentalize this type of thing where you've got all of the right folks. You've got the physicians and the nurses and the pharmacists all working together. What you have to do is really look at everybody who touches a particular condition. I'm really thrilled to have the opportunity to help support this kind of work. And that's kind of what population health is really all about. We're trying to get people to understand where and how they should be getting together and put together different initiatives so that they can do these things. I'm happy to chat with you a little bit. You know, I've already sent you an email so that we can connect later. But this is exactly the kind of thing we should be doing. Once you get all of the resources that you need to bear, you understand how to work the system and how to make everything flow better. I'm really excited by the things that I'm hearing from this group.
And I would add too, I think, you know, in our upcoming meetings, as we're wrapping up here, where we're hearing from some of the other healthcare organizations who we're working with, you know, everyone's facing similar challenges. And one of the kind of unifying themes, if you will, has been care coordination across departments and embedding some expertise in cardiology practice, just like Christine, right? I think that's a great model that we're seeing, you know, other folks dabble with in terms of how do we get some endocrinology expertise in the cardiology practice to be that go-to responsible individual or professional to oversee this particular, you know, therapeutic intervention. And so I think there's a lot of different flavors of how that looks. You know, what we'd like to understand more is what's motivating a healthcare organization to take that change, right? The data are strong that these agents confer these benefits. You know, while cost is certainly an issue, are we looking at, you know, tying, you know, longer term outcomes to value-based contracts, right? Reducing cardiovascular events and hospitalizations as a result of you know, longer term or midterm use of these agents. So how do we all collectively kind of make that case that healthcare organizations need to restructure a bit from a workflow standpoint to embed these experts in cardiology to take some of the load off? And I think that's going to be a theme that we'll hear more of on our upcoming meetings. And, you know, to everyone that's still here, thank you all for staying a little bit longer than our time. You know, any other questions that come up, please do shoot them over to me. I'm happy to get them to Aaron and his team to answer, and stay tuned for our next installment in a few weeks. I think, I don't know the exact day, I should, but we'll remind everyone that we'll be hearing from our other colleagues soon. So anything else, any other closing thoughts before we? Okay, well, thank you all so much again for staying a few extra minutes. Appreciate it. Appreciate all your time, and great job, Yair and team. That was really fantastic to hear all the different work. It really does take a village to make these changes. So thanks again.
Thank you for giving us the
Thanks.
opportunity.